Welcome, everybody. Nice to see you all. Thank you for joining. We're going to go ahead and we're going to get started. Welcome to Forming Community Partnerships. This is really a nice follow-up. We anticipate that you will have an opportunity to really dig into what you learned this morning from Adam. But even if for some reason you couldn't come this morning, we're hoping that you'll learn enough that you feel like you can really participate and think things through. That's really our goal for you today. So now let's look at the next slide. So this is available for CEU and CME. The major thing that you have to do is hang in there with us. You have to be here to get you got to be in it to win it. You got to be here to get the CEUs, and also you have to complete the evaluation. Let's get the next slide. Okay, so here are our presenters. I'll start with myself. I'm Suzanne Dobb. I am not a lawyer. I'm a clinical social worker, but I'm very excited and interested in value-based payment and the opportunities for us in healthcare. Leah, would you introduce yourself?
Sure. My name is Leah Montgomery. I am a senior consultant with Health Management Associates. I am a lawyer by training, and I worked at the legal aid office in St. Paul, Minnesota for many years doing government benefit work. But then I moved over and worked for the state Medicaid agency for many years. So I consider myself, at this point, more of a Medicaid policy wonk. I don't like to use the term wonk for myself, but I just did. So that I am a lawyer. I also know Medicaid, and I'm really happy to be here. Thanks. Adam.
Great. Good afternoon. Good to see hopefully most of you again. My name is Adam Falcone. I'm a partner with the law firm Feldman Tucker Pfeiffer Fidel here in Washington, D.C. And glad to be back and see how how we work through the examples today in this session and draw on some of the material that I shared in the first session in part one.
Thank you, guys. Let's look at the next slide and we'll see what we have in store today. We're going to be looking at some examples, as Adam just mentioned. Leah's going to walk through those with us. And then we're going to be working on another app. It's just a matter of, clicking a link and it'll take you right to that, that will allow you to independently work, just to be able to really take a moment to think through what have you learned, how does it apply? And then we'll take a break after that. You'll be working, you'll see when we get there, but you'll be working independently, but you'll also be able to see what everybody else is doing. So you'll have the opportunity to see how other people are thinking as well. Maybe you'll get ideas and inspiration from them. And then we're going to take a break, and we're going to then hear more about provider networks. Again, we're going to look at those examples that similar to what you just saw earlier. And then you'll be going into a breakout room that I'm calling Ask the Lawyers, because you'll have really, a whole 20 minutes with an attorney to both ask questions, to think about this together, and to hear how other people are thinking. Then we'll debrief that and we'll do an evaluation. So with that, I'm going to pass things over to Leah, who is going to talk about establishing the referral relationship that is so critical to being able to get to the kinds of outcomes that we want to achieve through VBP. Leah.
Thank you. Thanks all. I think this slide should look familiar to you. This was taken directly from Adam's presentation. But I think if you're anything like me, Adam's presentation probably got the wheels turning, and having an opportunity to try to situate what we've learned, in terms of an actual situation so that you can play around with those concepts is really helpful. So as we're going to go through this, we're going to use two hypothetical clinics. One's going to be a behavioral health clinic, the other's going to be a primary care clinic. And we're going to try to, see if we can walk ourselves through these analytic steps that Adam laid out as part of figuring out what kind of arrangement do we want to come to form a referral agreement between our hypothetical primary care clinic and our hypothetical behavioral health clinic. So I think we can move on to the next slide. Oh, I have the power to do it, my God. Okay, this is our clinic, the behavioral health clinic. And I think by the end of these couple hours, we all may be using the acronym RBH or just Rainbow, but this is the behavioral health side of things. And there's a couple of things that I think are most important to kind of keep in your mind as we work through this. Rainbow Behavioral Health has a lot of patients who are low income, who are covered by Medicaid. They have a large number, about half of their patient census has had more than 2 hospitalizations in the past year. 70% of their patients have had more than 5 ED visits. Some of these numbers are a little stretched just to help us wrap our head around the most significant facts, but I think that may not be completely out of whack, maybe not 70%, but I think a large proportion of people who are very low income certainly have many barriers to care. So use of an ED is probably pretty high. Another important fact are just how some of those poverty-related issues are impacting their health care. About 60% of Rainbow Behavioral Health patients moved in the last year, and 45% of those moves were caused because of an eviction. And another, I think, important, and this one slightly more positive and fun to think about, their patients, by and large, have a very high level of satisfaction with Rainbow Behavioral Health. And I think it's been my experience that this is pretty true to life as well. I think that they're maybe not 85%, but I think because of the frequency of contact between practitioners and people receiving services through a behavioral health clinic, especially a community behavioral health clinic, there tends to be a real sense of connection and engagement and trust. And I think you see that reflected in this fact pattern. We want that to be reflected in this fact pattern. 55% of the patients did not have a preventative care visit in the last year. 29% of their patients have an A1C above 9, so not well controlled at all. Their diabetes, I should say, is not well controlled. They do, when I say they, I mean Rainbow Behavioral Health screens all of their patients at intake for substance use, and about 35% of their patients are receiving some kind of treatment or support related to substance use disorder. And then finally, they have a no-show rate of about 38%. And the clinic does have an EHR that is able to generate a text message to remind people of their next appointments.
So Leah, I just want to pause before we go forward and just summarize. So this is like a very large behavioral health provider with a very vulnerable population. They're very poor, they're very medically fragile, and they have significant SDOH, right? All that moving also speaks to a lot of financial insecurity, particularly because of the eviction. And then this, this lack of attention to preventive care, more and more of like facing what's in front of me, taking care of the urgent, resulting in this poorly controlled number, the diabetes. And then, they have honestly a pretty average score for the SUD and the outpatient mental health. So I'm guessing some of the folks listening are kind of putting this together. Well, maybe we're not as big, but these are our folks, right? And we too struggle with this no-show rate. I don't know how many folks use the appointment reminder texts. I'd be interested actually to know, but I think this is a really nice kind of typical example. Like you said, maybe a little pushing the edge here, but this is the opportunity. These are the folks that are causing our spending rate in healthcare. This is that 5%, right? That causes this kind of like lack of a cost curve, that kind of right angle in healthcare spending around the country. Just
Yeah.
wanted to summarize, but yeah.
Resonate with you. Yeah, that was the intent. And I think that this does represent the opportunity. So now the goal is to try to marry that to a primary care provider who's seeing, essentially the same kind of population. It's a population with the same, level of poverty, the same level of coverage by Medicaid. They similarly have their patient census is, characterized by having multiple hospitalizations in a single year. Oh, thanks. And they have similarly patients that have quite a few ER visits. So, sorry, I was reading the wrong facts. They've had 20%, so that's not 50%, but that's a concern in terms of their patients as well. What you will notice, though, is that the preventative care clinic has a much higher no-show rate. They don't have a mechanism to do patient reminders using cell phones. My experience has been email is not a great way for a patient reminder because access to internet, access to a computer is challenging. But cell phones tend to be a little bit more amenable to, being able to make that contact. They have same number in terms of SDOH. That's, a lot of people who've moved in the last year. And I think the other significant fact, what we wanted to point out in this pattern was that there's lower patient satisfaction overall. So there's lower patient satisfaction. They've had patient satisfaction goes up based on the number of appointments the patient has had in the clinic. So the more contact a patient has had with the primary care team, the more there is trust and engagement built over time. But for the other half of their patient census, they just simply don't see people that often. Someone might come in for an annual exam, but that's pretty much it. And then I wanted to also point out, they have a lot of patients, 35%, who are currently receiving or taking behavioral health medications. So they already know they're starting with quite a bit of crossover with where a partnership with a behavioral health provider would be a logical step for them.
So you can really see where that partnership would make a lot of sense here. And I'd love to know of the folks attending this, if you wouldn't just mind just quickly chatting in BHPC, right? Where are you? What kind of organization do you come from? It'd be great to just see who we have here today. But I think part of what we see here is also, they share this stuff, right? They share these very, this poor community, folks that are, again, moving a lot. It's probably a pretty typical percentage in terms of the whole population of behavioral health meds being prescribed. Just as a context for this, probably 85 to 90% of behavioral health meds are prescribed in primary care. Now, of course, that doesn't mean 80 to 90% of the patients that go to primary care need those meds. That is probably closer to that 35% that are going to need the medication. But most of our medications are prescribed through primary care. And then we see that high no-show rate, which is very typical of primary care. They do better once they engage. And keep in mind, behavioral health providers are the engagement experts. They have master's degrees, sometimes PhDs in engagement. So, that's also a really nice resource for folks. So you can really see where these folks would be great partners, though. They share needs, right?
Right. They're in our hypothetical world. These are star-struck partners waiting to be connected through a referral agreement. So that should bring.
Oh, go ahead. I'm sorry. That should.
Oh, I was just looking. It looks like we've got some responses. I don't know if everyone has had a chance to jump into the chat, but it looks like we've got people that are on either side of this equation.
Yep.
So
That's great. Yeah, that's great. All right, so maybe right now, if you're anything like me, at the moment, I'm totally with you guys, okay? But on an average day, if I'm listening, I do tend to multitask. So I'd like to gently escort you fully back to the presentation. If you are multitasking, because we're going to do some work together right now. This is really a working session. So let's look at the next slide. We have 5 questions that we want you to think through. Imagine you are either a representative from Rainbow or from family practice, right? We want you to start to think about a referral agreement. What is it that your organization may need? And remember, some of those bolded areas, those may be some of the, the keys to where you might need things. So that's similar to question number 2. What are some of the gaps and needs that a partnership could address? So you may have gaps that only you can address, but what are the needs that a partnership might address? What are you looking for in an ideal partner, right? I'll tell you, for me, a bottom line is a reliable partner, right? That is like so important. But beyond that, what do you need? What are the skills that you need? What is the knowledge that they may have, or the capacity that they may have? And then what exactly are the services that you want a partner to provide? And it could be any partner. Maybe it's not Rainbow Behavioral Health or the family care thing. Maybe it's a housing provider or something like that. But what are the services that you need? And where can't you compromise? We are going to do this through another app, as I mentioned, called Mural. So this is what Mural is going to look like when you get onto it. Nahath is going to share a link right now. You'll be able to get on clicking that link. Before you get on, when you click, you're going to say you as a visitor. And then as you see here, this is an actual picture of what you're going to see. You're going to see the Rainbow Health and the family practice stuff that you just saw. You're going to have all the information that you need. You're going to see the questions that we just reviewed. And then you're going to see these like little sticky notes. And on the sticky notes, you can just start typing. Just click on a sticky note, you can start typing. If it looks like you're running out of sticky notes, if you have a lot to say, then we'll throw in some other sticky notes, or like a pro tip here is that all the little people standing at the bottom, I threw a little sticky notes in there, so you can just grab some of those if you feel like it. So you are, put yourself on mute, which I see you already are. You're going to be working independently, but while you're over there, you'll also be able to see what everybody else is doing. So that might give you some good ideas. If you're someone who's like, I really don't want to do this, then because I don't want to learn something new today. I just am wanting to listen. If you want to, you can contribute through the chat. So we'll keep an eye on the chat and we'll put your things in there if it starts to feel like learning how to do it is too burdensome. But I think once you get there, you'll see it's pretty intuitive. So go ahead. I see a bunch of you are already there, which is really nice, but go ahead, hop on. And hop, can I share my screen for just a minute? I just want to show folks something. Great, thank you. So let me get over here. Let me share my screen. And, so we begin to see that we're here. People have joined us. If you click on the white area, you can move the screen anywhere you want. If you want to make it bigger, which many of you probably will want to do, you can either, if you have one of these little rolling things on your mouse, you can use that, or you can come on down here to the lower right-hand side of the app, and you can zoom in using the plus and the minus sign. So I see a lot of activity, which is awesome. Again, please chat in if you either have ideas. In fact, Nahaf, can you put those questions in the chat? So that way, if you want to answer them through the chat, go ahead. If you're feeling like I want to do this and I don't know how, I'm frustrated, just go ahead and let us know, and we can, we can help you. So I'm going to disable all those cute little cursors, mostly because I think it gets a little distracting. And we'll see you in maybe about 12, 13 minutes. Let's give you some time. Sometimes we go to the trainings like this, you know, and we absorb so much information, we really don't get a chance to metabolize it almost. So just go ahead and give yourself some time to think about it, think about those questions, and see what comes up. Feel free to use either side. Feel free to answer on the rainbow side if you're a behavioral health provider. But if you're a behavioral health provider and you have something you really wish the primary care providers would be thinking about, feel free to jump on over that and put it in there. And same here. And I see folks are already contributing. So thank you so much. I'll be quiet now so you can think quietly. A family practice, medical practice, or a behavioral health practice, you might be asked to start to take on some of these things like that. Those diabetics that you know, end up with those high A1Cs that, you know, when not controlled, can lead to very expensive care.
And Suzanne, is it a fair assumption to think that the ED visits and the hospitalizations arise from physical health conditions or needs and not the behavioral health
Yeah.
one?
So my opinion is that all health is behavioral, right? So I think that even the visit to an ED is a behavioral choice, right? Certainly an A1C, you know, the things you need to do to control your A1C are huge, right? You need to be able to take the medication. You need to be able to control a diet that landed you in this place to begin with. So this is a habit that, you know, has to be changed. You know, and so you're talking to the clinical social worker here, but I believe that the clinical, you know, the behavioral health providers are one of the most valuable resources in value-based payment, because they know how to help people make behavior change. They may have been doing it to help people get like activated when they're really depressed, or you know, to reduce their anxiety, but they can use those same skills to help somebody figure out a strategy for taking a medication that they don't want to take, or for, you know, making a change in the way that they access healthcare. So I'm a believer that, you know, that it's all behavioral, right? I don't know if that answers your question, but that's my 2 cents there. It's a good question.
Adam, just so you know, when I was thinking about this, I didn't have the basis of, you know, the knowledge of a social worker, but I had my experience from working in legal aid led me to believe that for a lot of people, the most trusted provider in their life is their behavioral health provider. And that person plays a critical role in helping to do some basic health literacy around the importance of preventative health care in general. So I think sometimes, I think some of these questions may be difficult because, you know, it's not immediately obvious maybe why you might want to partner with a behavioral health provider if you don't want to grow your practice in that way. But I think, to Suzanne's point, there are issues such as social determinants of health and you know, the issue of patient engagement in general, which I think speaks to no-show rates, or frankly, even just being willing to engage with your provider. If you're having a hard time figuring out transportation to get to your appointment, if you can develop that level of trust, whether it comes, you know, through a partnership with a behavioral health provider, or if you develop that capacity internally. But I think usually it does, in my experience, it seems like behavioral health providers are the first ones to develop that degree of trust with their patients.
It seems like we don't have a lot of contributions right now. We have some really good ones. If you've just joined, I'm gonna put the link in again, because you may not be able to see it. Head on over to Mural, to this app that we're on. And I'm not sure, I'd love to hear in the chat, if you wouldn't mind, if you're not contributing, why not? Is it because you don't know how, you don't have anything to say, or you just don't feel like it? That would be really helpful for us to know, because it'll help us figure out where to go with this. Let me also just go ahead. I'm gonna, oh good, Nehat's already sharing her screen. Thanks, Nehat. And let's look at what we do see. So Rainbow Behavioral Health wants a partner with population health experience and experience with communication flows. And I noticed over on the family practice side, we also saw something about communication, communicating. If you can move on over there, if you can drag us on over there. Yeah, great, thanks. Keep going, all the way over. Yep, there we go. Help with communicating the importance of preventive care, right? So this is a great example. Like, you know, we all know about this, right? You go to the doctor says, I would really like you to start eating more vegetables because I'm a little worried about your cholesterol. And I know when I'm told that, I like to leave the doctor's office and I'm so nervous about it, I go have a piece of pizza, right? So the thing is that, you know, we hear what physicians and NPs, when PCPs say to us, we hear it, but it mostly like makes us feel anxious. And how great would it be if you could work out some kind of an arrangement? Imagine a partnership where a behavioral health person could even be in your office. And you know, much the way you might use them, much the way you would use a dietitian, but instead of providing more information about what to eat, that behavioral health person is going to help that person who has to make these big changes tackle stuff like, when I stop eating donuts, I feel so depressed. I feel so sad about having to make all these changes and I just shut down. So imagine having a partnership where it extends the recommendation that the PCP has just made to an action point. What would that be like to have that? And how might that impact your outcomes with, you know, any number of issues? In this case, we're looking at diabetes, but it could be hypertension, it could be cancer treatment. So what's going on? Did everybody leave? Is everybody like with that, Leah?
Oh, so I noticed from the folks that dropped into the chat what kind of practice they came from. There may be a fair number of people who are sort of one step beyond a referral agreement in their own day-to-day work lives.
Could be.
And, you know, I think just speaking to that, I think that part of what's helpful about taking a step back and sort of looking at these fundamental questions of what am I looking for? Where is there a gap? How do I fill that gap? And using the example of a referral agreement, there can be an opportunity for learning in terms of thinking through, okay, maybe I'm part of an integrated practice right now, but we haven't really pulled in social determinants of health. We don't have, you know, social workers that are there to help with, you know, public benefit applications and all that stuff. But I think conceptually, there's a lot of those same questions that can be useful to people, regardless of the type of practice they're in now, with an eye towards value-based purchasing and with the goal of improving health outcomes for all people. I think there's relevance for these questions in a lot of ways.
Yep, I agree. I like this comment here. What are the qualities of an ideal referral portion, they actually refer, right? So the other thing to be thinking about in a referral partnership is, can you structure it so that it's not just like, hey, I'll refer to you, you refer to me, and we all get more patients, which is great. Okay, everybody's happy. But what we're doing here, this referral process is really about, I'm going to refer to you and we're going to share the responsibility of improving an outcome. This is not just like, kind of referring back and forth. And yes, they actually refer. I'm reading as they say, they do what they say they're going to do. There's actually communication. There's actually a relationship, and and ideally a nice warm relationship, right? It's one where there's like real communication going back and forth. I'm wondering about, and I don't know if whoever wrote this here would be willing to speak up, since there aren't that many people, it might be a little more comfortable. The gap periods in reimbursement. What kind of partner, who would be able to address that? I think it's very interesting. It's an interesting need. Anybody feel like piping up a little bit? By the way, you may have noticed, but this is like completely anonymous. So nobody's going to know who you are if you put that in.
Can you guys hear me? My name is Dan Cronin. I'm the Executive Director of Capital Clubhouse, and I put that in. And I want to make sure that I put it in and it makes sense, because I'm brand new, and the gap period I'm referring to is the DBH gap period that's coming up. And I don't know that I can come up with any like immediate examples of partners where it would be impacted, but I would imagine that that could be impactful if you have an established or a pending partnership, is to forecast I guess uncontrollables such as a gap period where you have to make changes, and you're going to have to be nimble. So that's why I put that in.
Yep, that's great. Any thoughts, Adam, Leah? Any thoughts on the kind of place that Dan, or the kind of professional or agency Dan could go to get some help, essentially a little bit with revenue cycle, right? Is that what this is about?
Yes.
Yeah. Adam, Leah, any thoughts?
Well, I'm not familiar exactly with the gap problem, but I guess if I would take a stab at it, I wonder if any of your peer agencies have figured it out and could direct you either to an answer that they've developed over time, or through your state association, or maybe they have a consultant or a financial consultant that could help address the problem and give some ideas.
Mm-hmm. So this is an interesting, I'm so glad you just said that, because this brings us a little bit, and we can actually take down this slide, and right before we get ready for a little bit of a break here, this is a kind of a nice bridge topic, which is really this topic of then forming a network, right? So what are you going to get when you form a network? This is like an exercise.
Suzanne, you froze and I can't hear you anymore.
How about now? Any better?
Yep, we can hear you.
Can't see.
Great. So it really just, makes us think about what kind of a network, if we were to create a network, who would we want in our network? So right now we're just talking about provider to provider, but after the break, we're going to be talking about networks and really building this out in a much more robust way. And I think, Dan, to your point, you may want people in your network that can solve those kinds of business and financial problems for the network. So I think that it's very, it's hard to say because we're virtual, right? So we could be, everybody could be like reading their email, and that's why they didn't put anything in. Everybody could be like shopping on Amazon for their Whole Foods order tonight. I have no idea what you're doing out there. But what I will say is that if it's as blank as it is out there, could that be because this is just so different for us to start to think about being accountable for whole person care and being on the hook for it financially? You are going to be in a position where you're going to have to start to you are going to be in a position where you're going to start to enter into agreements and need partnerships to get the money that you've kind of got on the line here. And if you haven't been able to answer these questions yet, they're ones that you should really be thinking about. All right, let's take a break. We'll give you 12 minutes. Go read your email, go get a cup of coffee, do whatever works for you. We will see you back. Let's say 15-minute break. Okay, you guys, just to keep it even, it's 1:45. We'll see you back at 2 o'clock. Take care.
Rainbow Health Clinic has increased the number of its patients that have received a primary care visit in the last 12 months. That was an increase of 28%. There has been just a general increase in patients in the patient census for both clinics. There's been a huge reduction in emergency department visits for Rainbow Behavioral Health Clinic's patients. So that is a wonderful thing. They have been able to see some real movement, admittedly unrealistic and hypothetical. Certainly, family health has seen quite a drop in the no-show rate, and there has also been some improvement in the health of patients in both practices because there's been a reduction in the number of patients that had 2 or more hospitalizations in the past 12 months. So the question at this point for our 2 clinics is, how do we move forward and move ourselves into more advanced value-based purchasing models and the like. So at this point, we're going to move one slide ahead, and we have a poll. These are the topics that we'll be talking about in the breakout sessions. And the question is, first of all, what kind of value-based purchasing model should Family Health and Rainbow consider entering into? Should they consider something very modest like the pay for performance, or even something, it's not necessarily modest, but a performance improvement payment or incentive payment? Or should they jump in both feet into a total cost of care model with shared savings and shared risk? Or do they want to dabble in the I guess one can't really dabble in a total cost of care value-based purchasing model, but do they want to take a look at what it would be like for them to do an arrangement that allowed for them to share gain only? So the first question I see to think about is, what type of value-based purchasing model should they enter into? The second question is, what kind of network should they form? Would it be an IPA, an independent provider association, so that essentially, sort of like they had in their referral agreement, both of the practices continue to operate independently, but for the connection that's established between them contractually and whatever they agree to share through that new contract. A clinically integrated network is another option for them. So this gets them into really starting to change their individual practices such that they are working together, that there's more synergy happening in terms of how their practices interact with one another. And then finally, the accountable care organization, which again, just sort of builds on that model. I think maybe one way of thinking about it might be to think of more resources and supports that can help address health-related social need or SDOH, either by referral and sort of support navigating through public benefits and other resources that can help address issues like lack of affordable housing or not. And then the third question is, okay, what type of business entity should they form as they go forward into this brave new world with their new value-based purchasing agreement in mind, or value-based payment model in mind, and their new provider network? Do they want a LLC, and then do they want to be a for-profit or a non-profit? So we're hoping before we break out that we will get you to participate in the poll and let us know what your thoughts are at the outset. And then we will move into the breakout sessions, and those sessions will be an opportunity for all of us to discuss these questions and hopefully learn some things as we go through this. Okay, ooh, this is exciting. So 40% are saying a PIP, a performance incentive payment. Some are saying, 20% are saying, think about a total cost of care, but let's be a little more modest here. Let's be reasonable. Let's use a shared savings only. And then 40% of you have said, let's just do it. Let's just get into an ACO model. Let's use total cost of care, and let's use shared savings, shared risk. Shared reporting. I'm sorry, the poll said that. So anyway, we can talk about this in our breakout room. We can tweak all these things. And then the second question was, what type of network should they form? And it looks like there is, the winner is clinically integrated network. Although a close runner-up was Independent Provider Association. And then in terms of the type of business entity they should form, looks like nonprofit was the winner again, or not again, was a winner by 60% again, I should say. And that LLC came behind that. And I'm assuming that for LLC, people interpreted that as a for-profit corporation, limited liability. Okay, so this is good. This gets us going on our the next, I believe it's about a half hour. And
We are going to go ahead and then we're going to launch those breakout rooms. So you're going to be in a breakout room either with Leah or with Adam. And as I said earlier, this is your chance to ask the lawyer. Am I with Leah?
Yep, you were with Leah.
Thank you.
You're welcome.
Did you close the other one as well, or just this one?
All the breakout rooms are closed. We just decided to come back in together because there weren't that many folks.
Mm-hmm. Great, all right. So,
Not sure where everyone went.
well, they didn't really want to talk or ask lawyers any questions, you know?
Well, I mean, can you blame them? Really? Lawyers earn their bad rap sometimes.
Do you know what's do you have any line of sight into the other breakout room? No.
Yes, let me.
Because I can hop back in there.
Oh, all breakout rooms will close in 60 seconds, so they'll be back in a minute. They might just be having a riveting conversation in that room.
Well, I mean, if that's the case, we might want to leave them in there. Can you send me into that room for a sec? Let me go find out. I don't know if you're able to. Well, maybe you can like switch me. Or maybe not that now that you closed them. Maybe not.
Let me see what I can do.
I saw Adam.
So welcome back. Sorry for cutting the conversation short. We just had one person in our room, so we decided to bring everyone back together so that we could all talk to each other.
Caitlin, did you hear that explanation?
No, I missed it.
Why don't you repeat that for Caitlin?
Sure. Yeah, we just had a very small breakout room. So we decided to just bring everyone back together to make sure that we get maximum participation and can answer the most questions together.
Right.
Were you guys in the middle of a conversation? Did we rudely interrupt? Let's hear it. Let's continue that. Yeah.
We were talking about, I don't know if I can put you on the spot, Floyd, but Floyd works for a children's medical center here in Washington, D.C. and was talking about value-based arrangements. And I had offered a comment that I think hospitals are in a somewhat unique position in approaching value-based arrangements than primary care providers and standalone behavioral health providers, in that if some of these value-based arrangements are successful, they have the effect to reduce hospital admissions and ER visits. And so there could be a loss of revenue on one hand from those services that would normally be generated. And on the other hand, there could be an uptick in some revenue from pay for performance programs and shared savings, shared risk arrangements. But I think it's really hard to know, it seems in my perspective, to know in advance whether it's going to be equal out or be a result in a shortfall or result in a gain. And I think that's a challenge, I would imagine, for hospitals. And I had invited Floyd to comment on that.
I'd love to hear about that too, Floyd. I'd love to hear your thoughts on that.
Well, as I mentioned, we are in the preliminary stages, and we really haven't decided on how everything's going to be approached. But in truth, the hospital's in a real difficult situation from the standpoint that, for example, we are a specialty hospital, and a lot of times we get grouped into regular hospital, but children's is very specialized. It's a specialty hospital, and the reimbursement sometimes can be challenging because they think that we can be grouped into one category when we really should be grouped into our own separate category. So
where do you find that you usually get grouped? You get grouped
with the adults. We get grouped with the adults, and that's the challenging thing. They think that you can do the same with an adult as you can with a child, and that's not always so.
Yeah.
I was going to ask you, Floyd, do you, and I apologize that I'm piling on, you didn't want to be put on the spot, but I'm wondering, do you have outpatient clinics or outpatient hospital practices that would allow you to do maybe some planning to transfer where you would anticipate revenue growing in the future through clinics?
We do.
Okay. I mean, I'm not that I have any insight into whether or not that could even out, but it's interesting to try to, I think, puzzle through where would the value-based purchasing allow for growth where right now it might be too risky in terms of just maintaining your current line of business as well as investing what you need to grow in a place where you're interested in growing. But yeah.
See, all that's in discussion right now.
Yeah.
And, you know, like I said, as we muddle through this, you know, because we definitely have the services that we can perform to, you know, treat these patients, you know, from ambulatory surgery to behavioral health. We have the services. It's just working it out how it can best help us, you know, as far as, you know, because we got to keep our doors open, your revenue, and definitely care for the public. So,
Right. I it's really interesting to think about. I mean, just in general, it seems like the world. One way the human psychology kind of enters into this is how much risk seems reasonable based on your financial position, but also sort of in terms of your community position, in terms of the role that you play in the community. As I'm assuming many of the providers that are still with us are, you know, providers that are operating based on a mission and a commitment to meeting the needs of people struggling with poverty. So there's a lot at stake, not just loss in revenue, but also loss of, you know, capacity to keep the doors open. So it brings that's a different kind of analysis then.
well, fortunately, we're going to attract a lot of people, mainly because we are a children's hospital, and we're not just the floor that has that services pediatrics. So that alone in itself lets people know that, you know, we are here and we specialize in certain things. You know, like, for example, colorectal surgery is a big deal for us now that we've got one of the best in the world working there. And you know, if I'm sending my child anywhere, I'm sending them there, you know, if we have a diagnosis that's regarding colorectal. You know, so.
Yep.
I'm wondering, Floyd, about family engagement and how you guys handle that. How important is it so that when the patient leaves your front door to go home, are you right now as a hospital, are you on the hook for any outcomes at all? Things like, you know, rehospitalization, you know.
Well, you know, as a children's hospital, we're going to have rehospitalizations, and certain times it will be scheduled rehospitalizations. So we have that. And as far as us,
I meant preventable. Thank you for that. Not the scheduled, but the ones that, like, where the family's back in the ED, or, you know, things where you thought, well, we could probably, you know, we could probably have prevented that.
Well, we try to have as little of those as possible.
Right. Sure.
You know, but going back to what you were saying, we are very sensitive to the patients, and we really try and help the, you know, our staff go above and beyond to try and help the patient. We don't just take it lightly, you know, even the administrative, you know, when, you know, there are times when we receive phone calls when we really shouldn't receive phone calls, but we try and soothe the patient because it's bad enough that they have a child in the hospital. So we try and really go one step beyond to service the patients and their parents and the parents.
Yeah.
This is John. I'm also one of the contract managers at Children's as well. I want to give Floyd a little help here as well. Part of the discharge planning process for Children's is also to have a social worker be involved in the patient's transition out of the hospital, because we know that, as you indicated, throughout your whole dissertation and presentation, behavioral health is indeed a strong component to whether or not something is going to be repeated. And so obviously we're aware of that, and we do want to ensure that when the patient leaves the hospital, that they have a support system. And as you know, part of discharge is making sure that if they need DME supplies, or if they need any additional follow-up, whether it be behavioral health or anything else, that they have that as they depart the hospital. So yeah, so we do definitely try to take care of that component of it. And of course, you know, we are a multi-specialty pediatric hospital. You can compare us to maybe CHOP. And so, but we're highly specialized in NICU and as Floyd indicated, colorectal. But you know, we're the top, one of the top 5th hospitals in the nation when it comes to children's hospitals.
I mean, that's so impressive. And what it makes me immediately think about when we think about value-based purchasing is that you have a great value proposition, right? That you take care of this very special population, you know, not very special, but you know, highly specialized children.
The only concern, like and Floyd mentioned this, was with regard to the measures that, let's say, for example, if we enter into a value-based arrangement, the measures that we're going to be asked to make sure we maintain are not necessarily pediatric related. And so what happens is that we have to, and we are trying as best that we can, is to renegotiate those HEDIS measures that specifically can be more tied to dealing with specific pediatric care, because everything is lumped under adult, and so you're not really getting, you're comparing apples to oranges in that respect when you're doing a measure for quality of care. And so, you know, we have centers of excellence in many of our areas. So it is really fine-tuned and specific to pediatric care. So that's also an issue as well, because sometimes when you do enter into these value-based contracts with other insurance companies, they have a boilerplate arrangement and may not, excuse me, and may not always be able to to facilitate a better arrangement. So those are the kind of things that we find are challenging.
You know,
I was going to say that, yeah, there's tons of boilerplate arrangements that the MCOs offer, you know, and I think it's frustrating because some of them kind of pitch it as a take it or leave it situation. But I think in experience, you know, it's not really the case. There's actually a lot of flexibility and ability to negotiate, particularly for providers that are serious, essential providers to their network. And I would put a children's hospital right in that bucket. You're essential, you know, they can't offer a network that's viable if it wouldn't include, you know, the foremost children's hospital in our region. That would be a huge gap in their network. And I could see people not wanting to sign up with a plan that didn't have access if they had, you know, kids to that hospital, to your hospital. So I think that gives you a tremendous amount of leverage. I think just some of the plans are just not quite sure how to implement value-based arrangements, you know, and how to do them. It takes a lot of time and effort on their part to design some of these arrangements. And some of them have some capacity to do that. Others have less so. And that makes all these proposals, you know, inconsistent. And it's sort of like the chicken and egg. Who needs to propose it? Is it going to be the providers or is it going to be the plans? I'm not sure who does it. So if I see a plan not proposing it, I advise providers to propose their own value-based arrangements and try something out that's new for the plan if they're game. So Adam, let me ask you this. Have you been able to, in your experience, been able to work with, let's say, hospitals on the hospital side? Because of course, you know, there's two sides of the coin. You have the payer and then the provider. So in terms of the value-based
I represent I always represent providers. So I'm always on the provider side in the transactions. I'm not on the managed care side.
Okay, got it. Okay.
So I'm speaking to that experience.
Well, I'm wondering, well, two things. I just think it's really helpful to hear. I think maybe we should all tape record ourselves telling ourselves this and listen to it every day, that there is no obligation to take the value-based purchasing models being offered and as part of the MCO's boilerplate contracts. But I also think you brought up, John and Floyd, you know, this issue of your goals around value-based purchasing may not and the measures that you need in order for this to be an attractive proposition for you don't necessarily have to always directly align with the goals of your partners. I mean, there may be enough of a spread in terms of the kinds of benchmarks that you establish that there could be lots of ways for you to bring in different value-based models that would appeal more to what you would see as a necessary partner. I would imagine that your NICU serves premature babies frequently, and so I think premature babies come generally as part of a family system, and that, let alone their health status, they may be joining families that are already in the midst of different crises, whether those are economic or not. And I think trying to figure out where is there some alignment with your values, even if it's not a one-for-one. Maybe you need, I mean, I think you've made the case for why special HEDIS measures are necessary for a specialty hospital serving children. But I think there are lots of avenues to explore. Where can some relationships be developed that would bring in more of the supports for families at the point of discharge?
True, that's a valid point, yes.
I think, Elizabeth, okay. Elizabeth, I'm just going to read this out. What suggestions do you have for providers in negotiating terms for incentive payments in terms of, I should have opened up the whole, sorry, in terms of timeliness and transparency of reporting? I'm going to ask our resident expert, Adam.
I need to read it again so I get the full impact of the question. Okay, so the question has to do with negotiating terms of timeliness and transparency in reporting. Yeah, a major hurdle in getting reports from the managed care companies are accuracy and timely. They often are delayed and come too late in the process to actually do anything effective. You know, there's a big movement that any data that's reported has to be actionable, and if it comes too late in the performance year, it won't be very helpful in achieving the performance on any of the benchmarks or criteria that are selected. So my preference and strong suggestion is that if you have any performance-based contracts, pay for performance programs, total cost of care, shared savings, shared risk arrangements that are reliant on data from the MCO, make sure that you negotiate rights in your contract to ensure that you have access to those reports and data that you need. Some MCOs, you know, don't necessarily push out reports. They rely on the provider or the network to draw down reports, and you can do it at any time in a reporting, you know, month. So these prepackaged reporting systems, that's actually helpful in a way because you don't have to wait for the plan to generate the report. Anytime you can just pull down the numbers yourself at any point, any day and time. And they're accurate because it reflects exactly what's in the plan's claim systems. Other plans that don't offer that, that's where you need maybe a schedule of reporting in the contract itself that lays out each individual report that you think you need to do well on, under the value-based arrangement, and how frequently you're going to get received copies of those reports. And any consequences in the event the plan doesn't meet those deadlines in furnishing that information. Because that anybody has always told me the data is key for any value-based arrangements.
Well, I'm curious, Adam, because I was just thinking, well, what are the consequences to the plan? So what kinds of consequences have you seen written into an agreement that also holds the plan accountable for sharing that data?
Yeah, for a behavioral health provider, it wasn't in the district, but it was outside of the district. Behavioral health provider had a shared savings, shared risk arrangement where they were financially on the hook in the event that the benchmark wasn't achieved. And we wrote terms in the contract where if the plan didn't furnish the reports accurately, according to the schedule that we wrote in, that the behavioral health provider was held harmless from any downside financial risk. You know, was that a perfect remedy? No, because if they didn't get the reports they needed, they would miss out on the potential gains from the arrangement as well, you know, but at least it protected them on any downside risk under the arrangement, so they were held harmless. So it was an okay result, but you know, not a perfect result, because you can imagine the behavioral health provider being responsible for total costs of care was investing time and effort and energy into procedures and policies at their organization to manage the total costs of care. So if the plan didn't report information to them and they weren't successful in achieving the upside gains, they were still making significant staff investments of resources without any compensation from the plan if the plan didn't do its part.
I wanted to share what may be a misguided analogy to Battlestar Galactica. Hard to read the room, but that it was a science fiction series from my childhood in the early 70s, and then there was a remake. But one of the premise of their world was because they weren't networked, they are not as advanced in their computer processes. They were able to survive the I can't remember now. I think it was robots taking over. Anyway,
The Cylons.
The cyborgs. Yes, yes. Thank you.
Cylons.
Oh, cyborgs. Sorry. Yes. Did I get that right? Cybot. Anyway, feel free to use the chat for this function. But I mentioned that just because I think part of what has been a challenge for us, frankly, and I'm assuming maybe some people who've not spoken yet, there can be an asymmetry. You've got providers with more who've invested more and have more resources to invest into the development of value-based purchasing. And then you've got providers, and this tends to be community-based and behavioral health providers more often than not, that haven't been able to get as far in the process of developing up their infrastructure to support value-based payment models. And I think that one thing that I saw, I'm from Minnesota, so for full disclosure, that's why this may not resonate with you at all. Maybe it has something to do with the air in the Midwest, but I think not. I think that it's going to cover what is happening in DC. But what we found was that for providers that hadn't had the resources to invest in commercial products that would allow for immediate record transfer or, you know, I guess record transfer is what we were talking about. It's basically anything that wouldn't be dependent on claims as the source of information. In the end, they found that by simply developing trusted relationships between providers in multiple practices, they were able to achieve something that can't be achieved through claims-based data, which is they were able to anticipate when there was going to be periods of stress in a particular patient's life, and they were able to marshal all of their collective resources to make sure that that transition went as smoothly as it could. And then from that, they were able to build out both the kinds of value-based purchasing models that they wanted to use, and I think it helped them start pushing their own development of relationships, contractual or not, with you know, now I'm using the lingo, but I'm trying not to, the social determinant of health type providers. So social services providers. I know that that we had somebody with Clubhouse on earlier. And I remember Clubhouse being part of one of those arrangements where it was just sort of once the Clubhouse learned that something was coming up for somebody that was there, using the Clubhouse, they were able to then kind of make sure that all of the providers were aware, we've got this coming up, and they were able to, you know, make sure that there were systems in place to help that individual patient. So I mentioned that just as a way of, you know, I think it can feel so overwhelming if you have not been in this world for very long to figure out, how do I take that first step into value-based purchasing? And the hypotheticals that we put together for today were meant to sort of address two entities that had not gotten very far in value-based purchasing. And then, you know, they got 5 years under their belt with a referral agreement, and then they're ready to jump in. So I mentioned that just in case there's somebody who's listening who hasn't spoken up yet, to feel free to bring in questions that aren't quite as sophisticated as how do I negotiate new HEDIS measures. That might feel somewhat hard to match.
And I think also like this, that you bring up this issue of sophistication, Leah, and just thinking about these different kinds of networks. Which of these structures, you know, the IPA, the ASO, the CIM, ACO, all these networks, which are the ones that are, from that point of view, almost the safest? If you're a provider that doesn't have a lot of sophistication, but wants or needs to participate because that's a direction your area is going in, where are you going to be able to get the most support? What kind of structure is going to give you the most support? I'm assuming that's part of what you get when you join one of these networks.
Well, I think you can get that support. I think you can, I think some of the safety can come from how the business entity that you choose, and some of the support can come in terms of how you set up your reporting requirements. But I think in terms of, would an IPA or a CIN offer the sort of infrastructure and support that you would need to really start building out value-based purchasing? My guess is that it would come through a CIN, where you're using a little bit more of the muscle to just frankly practice those. They're sort of the basic customer, or I don't mean to reduce patient care to customer service, but I think that there is a certain part of patient care that is very analogous to making sure people get information, that they can actually use, so that it's not, not covering something that's not understood well by them, that they have a way to ask questions such that the questions, are answered in a timely manner, and because of that, they're more apt to ask a follow-up question. But I don't know, Adam, what do you think?
Well, I guess I start with the fact that in your example, after 5 years, the providers had a tremendous impact on hospitalizations, on ED visits and hospitalizations. And if you think about it from a financial perspective, who benefited from those fewer visits to the hospital? It wasn't the providers. They generated that value, but it wasn't the providers who gained from it financially. It was the insurance companies, and potentially maybe the district, if the rates premiums or rates went down. So I think the move to value-based is basically an argument to say the Family Health Center and the Rainbow Behavioral Health did all this great work in those 5 years to actually impact the outcomes and the health of their patients, and shouldn't they gain too financially? And so it doesn't matter to me if they form a CIN, ACO, IPA, whatever they want to call their network, doesn't matter. But shouldn't they have an arrangement as a network together so that they can financially benefit from the work that they did and continue to do, presumably, for their patients, that draws in additional resources? Because, Lord, there's many ways they can use those dollars to benefit their patients and plug in gaps and holes and address social determinants and do more for their patients. And so I think that they should, go after those opportunities, regardless of what they call themselves or whether they form a for-profit or nonprofit or LLC.
That's really helpful, because it also speaks to Floyd's initial comment that, with this whole move, it may mean fewer admissions, it may mean reduced, fewer sick visits, so then, like, where's that? How are you going to make that up? How are you going to get paid to keep people healthy, right? Not just to do sick care. What's the role of a hospital in keeping people healthy? And I'm wondering so as you said, hopefully these incentive payments are going to be the way to do that. That shared savings is going to be the way to do that. And I was thinking about some of the more, inexperienced providers that still want to be participating in a group. Is there a way, how are you, where's the safety net for you? Do you gain more of a safety net being in a clinically integrated network? Yeah.
Right. No, I think that's a great question. I mean, to me, most providers don't have the expertise and aren't set up to start negotiating managed care contracts. They haven't had to do it in the past. And they've always relied on, our traditional fee-for-service Medicaid delivery system for payment. And they've had advocates, their association, trade associations, their state associations advocated for reimbursement terms, and the district looked after them as well to some extent because they were important parts of the safety net. They don't have that same situation in managed care, but the network can kind of help bring everybody up. The networks can pursue contracts on their behalf and make sure that they're well protected in those contracts and advocate for them collectively for fair terms, and for participation in value-based arrangements. Having that intermediary, I think, is a tremendous asset. Even if you don't have value-based arrangements that are particularly lucrative, having another party, I think, negotiate the terms with the MCOs, and address, if possible, some of the problems that come up with getting paid and all the other burdens and obstacles and things you have to deal with. I think networks are extremely valuable for those arrangements and help the little guy, as much as the big guy that's able to generate value.
So just as a follow-up to that, and I'm like really taking advantage of Ask the Lawyer, you guys. I don't know if you guys have other questions, but I'm meanwhile gonna just take advantage. So as a follow-up to that, if I'm Floyd and John's organization, and I'm considering joining, or helping, being part of forming a network, what kind of data do I need? What do I need to know about my operations, about, fiscally, patient care wise? What do I need to know that I'll be sharing to really optimize the opportunity to get the most out of it?
I mean, I think you'd probably need to know first sort of what kind of value-based arrangements the MCOs have some appetite to engage in. I mean, certainly the hospitals, without losing any revenue, can do value-based arrangements that are pay-for-performance programs, right? Because those just add on additional dollars for achieving clinical benchmarks and that sort of thing, unrelated to total cost of care. I think you'd want to know how you're performing on some of those measures, clinical measures, and you probably do track them and understand the HEDIS measures that the MCOs use, and see if there's a good opportunity to create some measures that will generate additional financial revenues in addition to getting paid for services. To me, that's sort of the low-hanging fruit, because there's no loss in revenue from that situation. There's no downside risk under pay-for-performance programs, and you don't have these sort of contradictory financial incentives that you would have for total costs of care. So that's what I would start, with.
That's a good, I think the specialty hospital truly does have unique counter incentives, but it's interesting to think about, maybe taking this one step further, but knowing that DC's quality strategy includes a focus on maternal child health and maternal child outcomes, I would really be interested in trying to figure out, in terms of follow-up care, what's my best lever into making real behavioral changes that might, and behavioral changes, I don't mean like improve your moral character. I mean, make somebody more able to reach out, ask for help, to get travel set up to get to an appointment. Sorry, this is bringing up a memory of mine, talking to a group of FQHCs, and they were listening to a presentation about from the MCOs about how to make follow-up care easier. And one of the MCOs said, it must be really hard with an an infant and maybe a toddler even in Minnesota winters to get to a follow-up appointment on the bus. And it was sort of like, yeah, it is. So maybe, you know, figuring out, okay, once I spend a little bit of time putting myself in the shoes of a population that I think deserves a little more thought into very practical questions like transportation to an appointment, it might be that I see some value in developing partnerships with maybe not the go-to primary care provider who might be providing medical care as part of a follow-up plan, but maybe I want to reach out to a visiting nurse program or a program that employs community health workers where I can really start to get some support for families around very basic needs, core needs that will make all follow-up care possible. And I think it goes to your point earlier, Suzanne, that all care is behavioral health. I sort of think all care for people who have Medicaid coverage is also social determinants of health coverage as well.
I was just going to point something out as well, that even with these value-based arrangements, there's always a I want to try to say this as diplomatic as possible, but there's an additional burden to the physicians with all these different incentives that they're proposing, because many of the doctors don't have the time to be able to pull up 70 medical records or whatever the requirements are. It's just many of these small practices don't have the capability or the bandwidth to be able to have the staffing to pull all of these different reports and be able to provide all the measures, the immunizations, and all of the other things that are necessary. I remember when I used to be a provider relations rep with one of the MCOs. It was always difficult to walk into the doctor's office and say, "Oh, by the way, Dr. Johnson, we need 47 of these particular type of cases, and we need 37 of these, and we need these by, give me 2 days at most." This is pretty much the perimeter that they would give me, and I saw the face of the provider saying just how unrealistic can that possibly be? We're a small pediatric provider here, and so those are added issues that can cause a lot of hindrance as well for these providers to even entertain value based. But I mean, I understand the pros and cons, but this is an issue as well. It's just the additional burden to be able to provide all of this data.
Yes. Yeah, I think it is. And I think that we are probably on, I think we've already identified the problems with the timely sharing of data. There are certain problems just baked into claims-based data rather than data that can anticipate healthcare needs or sort of wellness planning rather than sickness care. And then I think as we get better and better about addressing social determinants of health, I think we just have a lack of data, period. If most Medicaid agencies in the country aren't making a distinction right now between African Americans and African immigrant families. And so right now, there's just a dearth of data around what are effective interventions in terms of making people, maybe I should frame it this, what are effective interventions at reducing barriers to care for different populations? So that doesn't provide any answers. I guess just an affirmation that it's a real consideration. And going back to sort of that type of partnership, what should you choose as a provider network? It does seem to me that there is real value in being able to figure out a way to at least push off some of that administrative burden onto a separate entity to do some of that work that you were talking about, John, in terms of being able to marshal your time and resources and energies for patient care and let some other arm of this partnership or network deal with reporting and data polls and things like that.
We have a couple more minutes left. Anyone else? Joe, Dan, Elizabeth, anybody else have a question or? Or John? Lloyd?
I don't. I just want to say that I found both the morning session and this session really helpful. So it's much appreciated.
Sure.
Good, good. Thank you for the affirmation.
Thanks, Dan.
Okay, I have one more question I can throw out there. What suggestions do you have for ongoing coordination and relationship management with managed care to sustain and ensure that VBPs are as productive and, you know, advantageous for everybody involved? Like, how do you continue to manage to keep those incentive payments coming and to preserve the relationship and repair issues over time, coordinating care for beneficiaries?
I think Adam's going to have a better, well, at least more relevant answer because he's got more familiarity with the DC market. But I will say, I have been surprised at once managed care, once you can find your people within the managed care organization, and by your people, I mean the set of professionals that are tasked with dealing with the issues that you are most concerned with. So if it is things like making sure you're getting the data on the schedule that you'd agreed to, if you can find your best advocate within the managed care organization, sometimes it's, I mean, I don't think it will likely be the data people within managed care, but if it's the government relations team, or if it is the behavioral health team, I think you will find that you've got people that are interested in working with you to try to help make, you know, rattle some cages and get what you need out of the MCO. And it feels to me like MCO staff that I've met over the years have been people who really are hungry to build up those kind of relationships and are just sort of at a loss as to how to do that, given the sort of political nature of, you know, I'm not going to say it's adversarial, but there's certainly a lot of baggage that both parties bring to those relationships. And it can be hard, I think, to just learn to navigate and get to a place where you feel like you can ask questions and get information that you can rely on.
I think I would add that, you know, population health work, you know, can happen on the managed care side just as much as the network and provider side. In fact, I think really good models of managed care is simply population health management for a defined population of patients. And, you know, there's a lot of contributing factors that make the relationships between the MCOs and providers and their networks successful. But, you know, one of the most important aspects really is how much the MCOs are getting from the state Medicaid agency in support of value-based arrangements. You know, I was thinking about value-based arrangements in Washington State with some of the behavioral health providers look so different there than in other parts of the country. And it's really because their Medicaid agency has strongly encouraged the MCOs to have these alternative payment models with those behavioral health providers and supported that. In fact, I think they even wrote into their model contract obligating the MCOs to share data for value-based arrangements with the providers and the networks in which they enter those arrangements with, to show that it's really important that they get the data that they need. And the agency knew that, and it became part of the contracts, and the plans went out, even in some ways that were not required in their contracts. The plans went out and had value-based arrangements beyond what was required in their contracts because they knew it was a priority of the Medicaid agency. And it supported those arrangements. And people at the plans that do some of the value-based work are different than the people at the plans that do some of the payment processing, the reimbursement processing work. It's a different group of people. And they can be very supportive of getting the data to the providers and the networks and supporting those activities.
Hi, my name is Joseph Morris. Speaking for the first time today. Can you guys hear me?
Yeah,
Yes.
I'm the administrator of a home health agency in DC, and I know it's a little different from what we've been talking about, but I'll add on to, and I've been trying to add to jump in every time, but I've been trying to figure where we fit in this, right? But one of the pieces we have, so one of the struggles we have, we're one of the largest agencies in DC, home health agency that is. And we are, I think, one of the best home health agencies in DC. One of the issues, and I'm excited about value-based this model for a lot of different reasons, because I think as an agency, with the model that we have now, some of the work we do, some of the resources we put into service delivery, we get the same rate as everybody else that doesn't put the same amount of resources into providing premium care, right? And I think this allows us to position ourselves to get something back, but then to continue giving excellent care to the patient. But one of the piece, and we've talked a little bit about behavioral health. We're frustrated as an agency because our census has a lot of patients with behavioral and mental health, but we don't get paid a rate for mental and behavioral health, right? The behavioral health agencies do, and a lot of them in DC are not doing what they're supposed to do. And it is putting this burden on us. I don't know if hospitals sees that as well, because a lot of behavioral patients are going to hospital for things that they shouldn't be going for, right? And the CSW and the resources are not there from those agencies. But I have caregivers that have to work with those patients for 16, 24 hours a day. And sometimes they're roaming the street, they're opening doors, and there's some of them that we just can't chase in DC no more, because we're not getting paid for. If we were getting paid a little bit more, if I had a rate that I had negotiated, I can tell my caregiver, okay, chase him down 10 blocks, do this and do that. But because we are a home health agency, we can only provide services in the home. So I don't know if somebody can speak to it again, because this market is new. I don't know where to even begin having that conversation, if I'm having it with the MCOs, or we've started to in the past to try to have that conversation with MCOs. Can you pay us more based on the patient diagnosis or because of these behavior else? But I think with this model now, we need to take a seat back just to figure, okay, how can it help us? If that makes sense to anybody.
it definitely makes sense. I mean, I think it makes sense. And is there an easy, or frankly, even if it's not an easy, is there an answer?
I'll add another piece real quick. I know you were speaking to somebody from Children's, and I don't know if it relates to children. We've had instances now over the last year that we had to go to MedStar and at least 2 or 3 other hospitals, that patients were there and they've passed the stage that they needed to be hospitalized in. Maybe they were hospitalized for about 6 months, and there was no caregiver or no home health agency willing to take those patients, right? And the patients didn't want to go to a rehab center, and they're just parking in a hospital bed, and that hospital wants them out, right? There are instances where we went, choked them, right? But that's this that patient, I'm getting paid the same rate for that patient. A lot of agencies are turning their back on that patient because it's a complex case, right? If they took that patient home, they have to put so much manpower in during the weekend or overnight, right? Admin resources into managing that case. So they'll say, okay, I'm not taking that patient when I can take 10 other patients that will get paid the same rate and won't require as much from me. So we haven't been shy. You know, there's a lot of the district will call us when they have patients like that. But my CEO is saying, Joe, okay, it's good we're helping the patient, but what do we get out of it? There's so many of these patients we can take, because if there's anything happens with that patient, they'll get a lawyer. Then Busman's office will be calling, everybody else will be calling us, but we don't get no added resources. And that's why I'm excited about a model like this. It's still required. We need to sit back and attend some of these calls and try to figure out what we need to do, put ourselves in positions to partner up with hospital, different partners, right? But that's the dilemma we have as it relates to those patients and patients with behavioral health diagnosis.
I think that's the key, what you just ended on, that maybe the right party to enter these arrangements with is not the MCO, but perhaps some of these other partners, being the providers, the hospitals, or the behavioral health providers, or the primary care providers or their networks that they form, because home health could be an important alternative for redirecting patients if you required enough resources, given the resources sufficient to, to take care of some of those higher need patients.
And Joe, I'm just going to give you the perspective of a Medicaid agency. I think that what you've outlined is sort of where there is a gap in our healthcare system around people who have not met the, and they could have not met this for many reasons, but they don't have the official disability determination from the Social Security Administration. So they're not people that are being served by dual programs that serve people who are Medicare and Medicaid eligible. And there's a lot of movement in that area to deal with people who are experiencing significant mental health symptoms, as well as who have needs for lots of other types of, physical health supports and resources. I think for the people that don't fit into that category, there's a real dearth of acknowledgement, frankly, that is a significant category, because it cuts against a bureaucratic sorting mechanism that exists. So I do think that coming together with other behavioral health providers and coming together with hospitals offers an opportunity to, frankly, gather data, look at the numbers, and then start making the case, obviously amongst yourselves, to develop partnerships that are offering you more opportunities for revenue. But I think there's also an opportunity to do some advocacy for a population that just does not fit easily into our existing system.
I agree.
I just wanted to say, so sometimes we have these scenarios where exactly around 5 o'clock on a Friday, I get a call from our nurses saying, we have to discharge this patient and they need to go to nursing home. They were basically looking for nursing homes to be able to send these kids to, and cannot find any. So what happens? They stay in the hospital, as you mentioned before, and they won't get discharged until probably, if they can find something next week of the following week. They were supposed to be discharged on Friday, and now we're talking about they're going to be discharged on Thursday of next week. So we have more patients now that we're trying to make sure that we can't move them because there's no home care agency. So this is a good opportunity as well for the hospitals to maybe negotiate directly with some of the home care and avoid having to go through the MCOs. The concern here would be that the MCOs may not necessarily pay for this type of reimbursement, and so it is a hole in the donut, like they say, where we're lacking that, because we suffer. The hospital suffers tremendously because we have to keep the child longer, and of course that raises cost and expenditures for everybody. So we understand how Joe feels, but because we're trying to find home care agencies as well, and the issue is sometimes the MCOs have barriers. So I don't know. It's just observations, and these are life experiences that we go through. But I get them on a Friday just when I'm about to clock out, and so I have to take care of the nurses. That's the children come first. So that's what happens. I just wanted to share that.
Yeah,
A great conversation, because we all started like very quiet, and it just really speaks to me around how much time we really need to kind of think and listen and begin to like connect the dots. I think unfortunately we're at the end, we're even a little bit over, but and we're just really kind of getting the wheels in motion. But I can feel them. I can really feel like the room here starting to really connect those dots. And I expect that we will continue having these conversations. And when you complete your evaluation, I haven't seen the whole evaluation, but I'm sure there's some opportunity to put your 2 cents in. And you might think about that. You might think about, what do we want going forward? What would be helpful to us as organizations, as agencies, to move. And maybe it's just these conversations, right? Maybe it's just these, beginning to kind of imagine it together. But I hate to be the one that has to end right now, but that is, unfortunately, I have to be that of the year and say that it's 3:05. What a pleasure it was actually having the opportunity to talk with you all. Here are the contact numbers and names. If you want to, if you decide you want to directly contact anybody that you've been speaking to. But I know.
Oh, you know what? I noticed that my email is not correct. I'm not with Feldman Tucker. So I should that you can reach L Montgomery at healthmanagement.com. Ooh,
Great.
Change in real time for
that
you.
was amazing. Okay. Thanks.
Yeah, thank you. What have we got coming up?
So I put the evaluation link in the chat. Thank you all for joining. Your feedback is really important to help us improve technical assistance offerings and improve programming as we move forward. And we really appreciate you taking the time to complete the survey.
Can you do me a favor? Can you go back to the last slide, because I wanna just take a look at I want to be able to just get that the correction on the email address.
Sure. And we'll also, I also put a link to the website where all of this material is going to be posted in the next few days.
Perfect. Thank you.
And it will have all of the links for you to reach out to directly.
Fantastic. Thank you. I really enjoyed this. Thank you so very much.
Thank you.
Thank you very much.
Yeah.
The website where everything's going to be posted on.
And
Good luck, DC.
Thank
yeah,
you.
good luck everybody, but we'll be seeing you around. So it's been an enjoyable conversation, and thank you so much for your participation. And we will
Take care.
have a good evening.
Bye, guys. Thank you.
Bye.
Thank you.
Thank you very much.